the opportunity. Um, so my name is Samantha Carson. I'm a PGY3 in the NAMPA Family Medicine program. We had an interesting case on the teaching service a few months back and received some feedback from the specialists weighing in on the case that you will soon hear about. But this was a good teaching case and learning case. So we've presented it, my junior resident, Dr. Bolaños, presented it as a case of the week a few weeks ago. And we felt like it was a good case to share some learning with y'all today. So thank you for the opportunity to present this today. I will correct briefly that it's cardiac abscesses or infective endocarditis. It's not aneurysm. No conflicts or disclosures for me today. Here's our goals and objectives. So we're going to define infective endocarditis, risk factors, symptoms, workup, and treatment, and go through all the details there. Kind of the agenda, how I'm going to go through that. What I'd like to do is present the case that we encountered to y'all and kind of have you go through some of the diagnostic reasoning with us or with me. And then we can explore some of those goals and objectives as they relate to the case and kind of some takeaway from those as well. So our case today, we had a 41-year-old gentleman. He first presented to an outpatient clinic, no past medical history, just a chief complaint of some fever and chills, as well as headaches. And at that point, they'd been ongoing for about 4 days. His vitals were pretty normal, no pain, no fever at that point in the office. His physical exam was unremarkable. They did do a CBC and CMP, and just of note, the white count was marginally bumped at 12.5 or 12.9, sorry, and neutrophil predominant. His CMP only remarkable for a bilirubin of 1.3, and they did test for COVID, and that was negative. He was diagnosed with a viral illness and told to kind of just follow up as needed and go home and do supportive cares. A couple days later, he was called about his lab results, which I just shared with you, and he reported feeling worse. So they scheduled him for a same-day telehealth visit at the same office. The same provider saw him. And he denied any new symptoms, but hadn't had a fever actually for a couple of days and just continued chills. No exam, obviously, with a telehealth visit. And because the patient was so concerned about his symptoms, a smear was ordered on the original CBC, and I have been unable to find those results. So he was just counseled to continue follow-up and supportive cares as needed. No real new diagnosis or other information. The third encounter was on July 30th. So about 5 days later, he again presented to the same clinic. He said he'd been having fever now for 11 days. His max fever had been the day prior with 100.3, which I understand, not a fever, but low-grade temps at home that he had been measuring and following. Normal vitals at that time, but he did appear toxic and frail and pale. So the same provider, fortunately, noticed that this was ongoing and sent him straight to the emergency room. Okay, so on arrival to the ER, normal vital signs. Chief complaint was 12 days of fever. He reported at that time that he'd had a fever of 103 that day, but also new symptoms of losing balance and severe fatigue. The HMP, because he ended up being admitted, also reported that he said he was having some confusion and neck pain. Physical exam, again, unremarkable. EKG notable for sinus rhythm with the first degree AV block, and a QTC of 459 with some evidence of LVH. Labs at that time, white count significantly bumped to 25, neutrophil predominant still, AST and ALT were markedly elevated, 211 and 199. His CRP was 205, procal elevated to 4.8, lactic acid was normal. And then they trended his tropes, 0.04 to 0.09. His CT of chest, abdomen, pelvis was read as negative for any acute abnormalities, and they did start blood cultures. He was admitted to the hospital due to infection of unclear etiology. He also reported, real quick, in addition to the loss of balance and fatigue, some diarrhea and difficulty walking. Okay. Other labs I wanted to add, just ran out of room on this slide, sorry. So just negative COVID flu, TSH mono. And then here is his EKG for you all to look at. You can see there's definitely more than 5 small blocks between his PR or his PR is definitely more than 5 small blocks. Better way to say that. Okay, and then his CT chest, abdomen, pelvis, I'm leading you a little bit here, but it doesn't quite look like this aorta lacks any inflammation. Hindsight is, of course, 2020. But we will continue to explore that. Overnight in the hospital, he was started on 2 grams of Rocephin. He mildly felt improved in the morning. He did have a max temperature overnight in the hospital of 102.6. So his antibiotics were brought in to include vancomycin. Because of the neck pain and concerns about confusion, one of the ER providers attempted an LP and was unable to get a sample. His troponin peaked at 0.13. Acute hepatitis panel was negative. A rapid respiratory panel in the morning was actually positive for rhino and enterovirus. HIV was negative. Interestingly, West Nile IgG was positive, but IgM was negative. And then an autoimmune panel was run, which was negative with the exception of F-actin IgG antibody, but anti-smooth muscle antibody was positive. So autoimmune hepatitis was considered as an explanation for those elevated liver enzymes. So at that point on technically hospital day 2, after his admission on 7/30, so we're talking about 7/31 here, we're still working with an infection of unknown etiology. The differential was pretty broad. Between the admitting hospitalist, the ER provider, and then the day team on 7/31, as well as some a very sleuthy case manager, we kind of gathered all of these contributing factors to the patient's infectious risk. So he did work on a dairy farm with cattle and chickens, and he did provide veterinary care to the animals, trained, unofficially trained by a licensed veterinarian. He has 7 children, 6 of them were minors. There was an outbreak of avian flu the same month at work. He didn't have any IV drug use history. A few months prior to this, he had gone to England with his wife and had consumed unpasteurized dairy products while there. And then he had been without insurance or any kind of dental coverage for years and had recently been reestablished with dentistry and was getting every 3-month cleanings to kind of get caught up. So his most recent every 3-month cleaning was in June. So just to review at this point, on top of these risk factors for possible infection that we still don't know the etiology of, the concerning symptoms that we're trying to piece together were confusion, fatigue, some neck pain, which actually on further review turned out to be anterior, not posterior, so less concern for meningitis. The elevated temperature up to 103, fever on and off for 11 days, 12 days at this point, generalized malaise. And then on 7/31, the new finding of a systolic murmur. Telemetry monitoring was started when the patient was admitted, and that also showed that he had on top of the first degree block that showed on that was evident on the EKG at admission, it had progressed overnight to second degree block, but no respiratory symptoms. So I just wanted to pause here and kind of put all of this information kind of summarized for you, and then ask you to kind of weigh in on what kind of things would be on your differential.
Do you want people to unmute to do that, Dr. Carson, or put it in the chat?
Either way.
Hey Sam, it's Pennings. Really interesting case. I think some of the historical nuances of animal exposure and certain food exposures make it kind of interesting in terms of different directions you could certainly take this in to consider for diagnoses. I mean, I still think about a lot of the common things, with fever and fatigue, elevated liver enzymes. I think you have mono and mono-like illness, which can also cause an encephalitis kind of a picture. It's certainly good to rule out the no IV drug use history, thinking about bacteremia and endocarditis from that. And certainly thinking about tick-borne illnesses, which really aren't super common in our area. Even Rocky Mountain spotted fever is only called that because the first diagnosis was made out in the West, but it's really predominantly Southeast United States, and then Lyme disease being more in the Northeast. But I'd still be thinking about some of those tick-borne illnesses that can present with these kind of nuanced, off and on fever, and just worsening fatigue and just not feeling well. Yeah, those would be big things in my differential.
Awesome. Thanks for weighing in, Pennings. Anybody else? I will hint that some of the things we considered are rarer things that we may not have heard of since medical school. So it's kind of an exotic case, as Pennings mentioned.
And I think also good to think about some of these autoimmune and rheumatologic conditions that you were thinking about that could be driving this as well. So maybe non-infectious etiologies that could be driving this. So also opens up the differential to that. I wouldn't think necessarily oncologic with this presentation, with how fast it's kind of come on. It seems more something inflammatory or something infectious driving it more than something malignant.
Very true. So yeah, really super broad differential, as Pennings pointed out: infectious, inflammatory conditions, less likely neoplastic, but we really cast a broad net, recruited infectious disease. And I think the infectious disease doctor really kind of honed in on the exposure to dairy in England, and also just the ongoing exposure at work as the primary risk factors. So overnight, the blood cultures also were both positive within a few hours of each other, just a smidge after the 24-hour mark, for Haemophilus parainfluenza. We've got multiple positive results so far, and lots of different directions to go into. We included Coxiella and Brucella on the differential as well. So because of the AV block that was progressing and the bacteremia, however, we did consult cardiology in the morning on the 31st and proceeded with echocardiogram. On the transthoracic echocardiogram on the 31st, sorry, that's a typo. The findings were concerning for some aortic valve vegetation and endocarditis. So we continued the ceftriaxone and the vancomycin as per the admission. But the infectious disease and cardiologist decided to proceed with the transesophageal echocardiogram the next day. That was concerning for a bicuspid aortic valve, but also vegetation and extensive perivalvular abscess. I will just read a piece of the echocardiogram results because I think sometimes when the reporter uses extreme language, it draws my attention at least, and I think that it kind of helps impress on y'all the urgency of the case a little bit. So extensive perivalvular abscess is also identified extending from the atrial side of the aortic root and valve plane to the base of the anterior mitral leaflet along the interatrial septum. Moderate aortic insufficiency and trace to mild mitral regurgitation. Of course, we don't have a prior echocardiogram for this gentleman, so we're acting on the belief that he had a normal heart prior to all of this, with probably a bicuspid valve, aortic valve. So because of this echocardiogram results, the plan was to switch from ceftriaxone to cefepime, stop the vancomycin, and then because of the infectious disease, doctors' concern for brucella in particular, doxycycline, rifampin, and gentamicin were all added. So super broad coverage. This is just a picture to kind of demonstrate the extent of the abscess. So these two cusps at the anterior aspect of the aortic valve were fused. And then the abscess kind of extended along the posterior cusp here and into this cusp of the mitral valve, as well as down this interatrial septum. So this is an excerpt from the infectious disease doctor's note on the 1st. He was very convinced that it was Brucella species, less concerned about Coxiella. This unpasteurized exposure a few weeks prior in England was kind of forefront on his mind, as well as his work exposure. So he did not feel concerned at the time about the Haemophilus parainfluenza, thought it was kind of an incidental finding on both blood cultures. Because of this and because of evidence of progressive block, as well as patients' report of chest discomfort overnight from the 1st to the 2nd of August, things were kind of moved along quickly. He was transitioned to the Boise Hospital so that he could be closer to the cardiothoracic surgeon team, and planned for some kind of intervention because of the extension of the abscess around the aortic valve. However, our local cardiothoracic surgery team had never performed the kind of procedure that he required. And so they suggested he be transferred to the University of Utah. And that transition was delayed due to bed availability. So while he was waiting on the second day of August, he developed third-degree block. His primary physician managing him in the hospital was really concerned about embolic phenomenon, but was counseled not to use any kind of anticoagulant by the cardiothoracic surgery team. The blood cultures speciated at that time. They were positive just for gram-negative rods up to that point. I apologize. I gave that one away early. And then just seemed to progressively get a little bit worse, but was on the 4 antibiotic regimen that I discussed earlier, the cefepime, doxy, rifampin, and gent. So he did get to Utah on the evening of the 2nd, and then on the 3rd, sorry, this is EKG on the 2nd before he left for Utah, just to demonstrate the dissociation between the P waves, which you can kind of see hiding in here, from the QRS complexes. It's a good 3rd-degree heart block EKG. So he did get to Utah, as I said, on the 2nd, and then he was scheduled for emergent surgery on the 3rd. The op report listed the diagnoses as aortic valve endocarditis, the bicuspid aortic valve, the periannular aortic abscess, an aortomitral curtain abscess. Curtain is not a word I think we encounter a lot, so I thought that was a fun phrase. And then complete heart block. So during the procedure, they did a patch reconstruction of the aortic annulus and aortic valve replacement, and then replaced the aortomitral curtain with bovine pericardium. They did also, because of the complete heart block and their belief that the abscess had destroyed the conduction system in the heart, they placed 2 leads into the right atrium and ventricle, anticipating the need for a pacemaker. A fun quote from the op report: the aortic valve annulus was completely destroyed by an abscess due to the dense heart block and likely destruction of the conduction system due to endocarditis, infection, and abscess. We elected to place epicardial pacing leads. Completely destroyed. All right, so, oh, and then they repeat to the sternal wound edges. The infectious disease physicians at the University of Utah had a different opinion than the local infectious disease doctors here in Idaho. They attributed his abscess and endocarditis to the Haemophilus parainfluenza growing in the blood cultures. A second group of blood cultures was collected after the first one was positive, so after antibiotics were started, and they never grew anything. So 2 out of 4 total cultures were positive for the Haemophilus parainfluenza. And then those infectious disease physicians felt that brucella was really not a concern because of reports that brucella has been eradicated from U.S. cattle herds. And so that would be a really rare occurrence. Haemophilus parainfluenza is part of the HACEK or HACEK group. And so that's a common source or etiology for infective endocarditis, which we'll get into a little bit more. So they transitioned him back to ceftriaxone 2 grams every day and stopped the other antibiotics. Ceftriaxone is adequate coverage for the Haemophilus. And he was in Utah for a few more days. On the 5th, he had his leads connected to a permanent pacemaker, and that procedure went well. He was discharged from Utah on the 10th. On the 20th, he was seen here in Idaho by the infectious disease physicians, and they helped coordinate his 2 gram ceftriaxone daily here via PICC line. And then on the 11th of September, he was seen by cardiothoracic surgery. And at that time, he wanted to start doing push-ups, so was feeling very well. His energy had returned, and he wanted to be much more active. So he was counseled to wait a little bit longer. He did finish his course of antibiotics. As of his most recent outpatient follow-up visit on January 10th or 11th, he was doing very well. No recurrent signs of infection. And he has not yet established with cardiology locally, but is being cared for by his PCP. So to the learning points with this case. So cardiac abscesses or infective endocarditis, to define them, we'll get a little bit more into the nitty gritty of how we do that, but kind of an overview of the components of this illness. You have to have evidence of bacteremia or fungemia, active valvulitis. Often there's peripheral emboli or immunological vascular phenomena, but that would be like a classic case to have all four. More often than not, not all four components are present, which makes this sometimes a elusive diagnosis. Risk factors for this, there's the obvious things like transcatheter valve implants or repairs. So of course, as the incidence of those repairs and also pacemakers and lead placements in the last 20 to 30 years, the incidence of endocarditis has increased correspondingly, understandably. Prior history of infective endocarditis raises risk of future recurrence. I believe the risk is somewhere between 5 and 10%, mostly associated with people who it seems don't get complete or adequate treatment of their first round. So use of only antibiotics when there's evidence of vegetation and valve destruction, for example, would be more likely to lead to recurrence. Rheumatic heart disease or congenital heart disease also places people at higher risk. I was unable to find if the bicuspid valve in and of itself for this gentleman raised his risk, but to my mind, that seems a possible contributor. And then of course, IV drug use. Symptoms. So generally symptoms of heart failure, because what the patient's probably experiencing, particularly with left-sided endocarditis, is aortic valve insufficiency, left ventricular volume overload, and then the heart failure symptoms that we see all the time, fluid overload, pulmonary edema, shortness of breath. New cardiac murmurs are the obvious thing. I think I tried to point out as the case evolved at what point we noticed a heart murmur. A 2 out of 6 heart murmurs found on the second day of hospitalization for this gentleman. So not a dead giveaway. And of course, we encounter people much older than him with history of heart murmurs. So not necessarily endocarditis all the time. A new AV block. I think this was the biggest finding that pushed this case forward. This progression from first degree AV block to second and then third within a day makes me curious what an EKG would have shown earlier in his case. Probably normal, but it would have been interesting to see the progression. But this is evidence of extension of the abscess in particular through the conduction system. New arrhythmia, similar explanation, just contributing to poor conduction through that conduction system. Workup. So again, I'll get more into this in just a second, but echo is the kind of gold standard here. TT, transthoracic obviously is your first line, but esophageal has been preferred. More recently, in the last 5 to 10 years, cardiac CTs have been used because they can slice a little bit thinner through that heart. They can sometimes get a better sense of the extent of the valve or extent of the abscess, excuse me. And so can sometimes have an earlier diagnosis. That said, they're harder to get a hold of. And even more hard to get a hold of is a PET scan. But those are apparently, according to the literature I read, becoming more in favor. Harder for us in rural areas of Idaho, of course, to get a hold of. Blood cultures, standard of care, like the symptom or like the definition implied, bacteremia or fungemia are kind of a big component of this diagnosis. And then EKG or telemetry changes as the AV block and arrhythmia should be kind of documented and watched for evolution. Treatment. So standard of care for suspected infective endocarditis is ceftriaxone and vancomycin. And then changes to that should be directed by cultures. This is definitely a case where you want a multidisciplinary team. So cardiothoracic surgeon should be involved early. You know, looking back through this case, I think to my mind, a big question was if we had waited too long for cardiothoracic surgeon involvement. And I think certainly if things had not gone as well as they had, that would be a question that would have come up on peer review. Infectious disease, obviously a huge component to the team here and management of antibiotics. I find it super interesting that there was such a difference in opinion between doctors here in Idaho and in Utah. And the pearl of information that brucella is really not a high risk in the US because of eradication from cattle herds, I think is a kind of a pearl that I'll walk away from as fun as it is to think of exotic diagnoses when considering a differential. And then obviously cardiology, electrophysiology was involved in this case and probably would in many other cases of IE as well. As I mentioned earlier, prognosis for these individuals that have infective endocarditis is somewhere in the 5 to 10% recurrence. Mortality is associated with the extent of infection. So for this gentleman to have this abscess that extended into the interatrial septum was starting to show evidence of effects on the mitral valve, had already kind of destroyed, not kind of, but had destroyed the aortic valve. And was invading or showing signs of invading the conduction system. You kind of that really what are the words? I was blown away by how fast and progressive it could be, and how much destruction it could cause so quickly. So it's amazing the technology we have and the ability to repair what's been destroyed in the heart to make mortality less likely for some of these individuals. Predisposing conditions, as I listed earlier. So anybody with a history of valve repair, pacemaker, I think this, since this case has occurred, I've kind of lifted infective endocarditis out of the depths of my differential to a little bit higher, just to be more aware of this because of its potential to be for a terrible outcome. And then I think IV drug use, we often jump to vegetations and such. So I don't have as much trouble jumping to infective endocarditis for that risk factor, but it's something to watch for as far as recurrent prognosis as well. So the big teaching point here, I think, is that I wanted to share with y'all is about the Duke criteria. So I've summarized a little bit in the last few slides what you can find in the Duke criteria, but this was a consensus statement basically between cardiologists and infectious disease doctors. It is initially published in 1994, and it was offered as a way to kind of get infective endocarditis on the map and like, or not on the map, but like on our radar, and have ways for us to kind of make it more or less likely. So there was another kind of scale prior to that that was not as sensitive and specific as the Duke criteria. And then most recently, the Duke criteria were revised in 2023. And it's not, those revisions have not been, I don't believe they've been investigated yet for whether they're actually improvements to the prior modified Duke criteria that were last revised in 2000. But I think the changes that they made are pretty minor and reasonable. So I would expect that the research will pan out in its favor. So there are a list of major criteria in the Duke kind of rating system, and then minor criteria. And then you can see here in the center of your slide, you need 2 major or 1 major and 3 minor or 5 minor criterion to kind of meet the diagnosis. You will recognize some of these criteria based on what we've talked about already in the case and then in the slides after that. So it's interesting to me. It's divided into definite, possible, and rejected based on whether and how much criteria are met. So major criteria, microorganisms on separate blood culture sets. So for this gentleman, for example, we had 2 separate blood cultures positive for Haemophilus. Less likely microorganisms to cause IE, they have to have 3 blood culture sets. Then the I think one of the pearls from this case, and one thing that I wanted to make sure was highlighted in this presentation, is that we don't some of the things on our differential, like the Coxiella and Brucella, for example, are have blood culture growth requirements that we don't commonly use. And so negative blood culture infective endocarditis is a thing. And so we have to consider doing additional workup to investigate whether those infections are actually present when we just haven't done a good enough job looking for them. There is research on the incidence of negative blood culture infective endocarditis, and subsequent investigations show that like half of those negative blood culture cases do actually have something present that we just didn't look for very well. So PCR, use of PCR or FISH studies is becoming the trend for looking for those other alternative diagnoses. Imaging criteria, as I mentioned earlier, echocardiogram has been kind of the gold standard. CT is coming more into favor, and then PET studies are listed down here as a new option. This surgical criteria is a new addition to the 2023 revision. So if by chance the surgeon is the first one to find evidence of infective endocarditis, that does qualify as a major criteria for this diagnosis. Microorganisms, so as this slide suggests, microorganisms that commonly cause infective endocarditis. These are some of the ones that are kind of highlighted in the literature. Staph aureus and Staph lugdinosis. I've never seen that one before. I apologize for butchering that. Staph or strep are the most common, not strep pneumoniae or strep pyogenes. And then this HACEC group where Haemophilus is found is the next most common. The entire Haemophilus group is included, including parainfluenzae, which was this gentleman's issue. But parainfluenzae is the most common Haemophilus subspecies to cause infective endocarditis. Other things to consider in this right lower corner here, Pseudomonas bificalis, Corynebacterium serratia, things we see in other infections, of course. So I just wanted to loop back to this case and kind of discuss again some of the positive results that we found, and kind of explore the idea, if you will, that in fact this gentleman may have had more than one infection going on, and or may have had some results that were false positives that we can explain for other reasons. For example, the West Nile positive result can be, it's a false positive often when other viruses are present. So I kind of was wondering if maybe the rhino or enterovirus triggered that. The Coxiella was positive in a gentleman who had IgG phase 1 and 2 positive IgG for Coxiella, but no IgM. That suggests an acute infection, but an acute infection for Coxiella is within the last couple of years. Not, I think it's beyond 3 years is when IgM can be present. And without, with only a couple of days of doxycycline, I think the likelihood that this was actually present is low, but certainly possible. It was probably inadequately treated with only a couple of days of doxycycline, but an interesting inclusion nonetheless. The serology for brucella ended up being negative, so I think the concern of the local infectious disease doctors that was regarding the brucella exposure doesn't seem accurate or on point there. And then just a brief review of the Haemophilus parainfluenzae. The Haemophilus species colonizes the GI and respiratory tract. We usually think of Haemophilus influenzae, which is one of the 6 types of encapsulated Haemophilus that's more virulent, but we can have colonization with this group of organisms and not necessarily have symptoms. And so I think one thing that was not explored in this case was where that gentleman may have picked that up and whether his recent dental procedures or his 7 children or some other source may have been the more likely explanation for all of his medical events. I think that I covered all of those. Okay, and that brings me to the end. I have just a couple minutes more to hit the 45-minute mark that Liz set for me. So does anybody have any questions about this case or any additional information they wanted to contribute?
Do you feel like the differing of the opinions like kind of came as like the ID group in Utah got more information, or they were like from the start, like, I think this is the Haemophilus that's driving this, like once the patient was transferred?
My impression based on reading the notes was that they were insistent from the beginning that it was the Haemophilus. And they
Got
reached
it.
out. Yeah, and they reached out to the St. Luke's microbiology lab and were following along as that was kind of those results were evolving. So the first note that I read from infectious disease in Utah was insistent that it was not brucella.
Okay. And that's the one you said that essentially is eradicated from
Yeah,
the
that was
US.
the comment, was that it was eradicated from general cattle herds in the United States.
Okay. And then did he ever like develop evidence of like septic emboli, like Osler nodes and Janeway lesions and all that stuff?
No, thank you for reminding me. Those are the vascular evidence that was kind of listed as the fourth criteria, is the definition of infective endocarditis. And I do know that early on in this case, on like the first and second day of hospitalization, those kinds of things were looked for and were not found. There was no comment on those after that.
Okay, got it. Yeah, interesting for like a left-sided.
Yeah.
Yeah, cool. Just on my end, thank you for presenting this case. It was a really good one, really interesting, and I think you did a great job just kind of following it from start to finish. So we can kind of see every step of the way, and as more information was coming in.
And we have, first of all, thanks, Dr. Carson. That was great. We have a couple comments in the chat about what a great presentation it was and what a nice job you did and what an interesting case it was.
Thank you.
Are there any other questions? Either unmute or share that in the chat. Well, as I shared at the beginning, this will be in the CME publications area of the IdahoFamilyPhysicians.org website in our CME library. And I'll get that up in the next month. If you needed CME, please make sure you either email me or completed the Google form. Our next grand rounds is February 10th with the ERMAC program, same time. And then we hope you all will get registered for the IAFP annual conference. I'm actually going to drop the link to register for the conference if you aren't already registered. May 16th through 17th in beautiful McCall, Idaho. Please go ahead and register. Anything else you want to share, Dr. Carson?
No, I think that's everything. I just thank you again for the opportunity to present this case.
Great. I hope everybody has a nice day, and thanks again.